Hello, everyone, and welcome back to our series on AI and healthcare, hosted by InpharmD. I'm so excited because today we're joined by Dr. Andrea Sikora, an expert in the intersection of artificial intelligence and EHR integration. Dr. Sikora, thank you so much for joining us today. Do you mind taking a second to introducing yourself and sharing a little bit about your background and your experience in AI and healthcare?
Wonderful. Thank you guys so much for having me. So my name's Andrea Sikora. I am a critical care pharmacist by training. I went to the University of Georgia's College of Pharmacy, did 2 years of residency training at University of North Carolina before taking a position at University of Georgia's College of Pharmacy and the faculty in a faculty role. And I completed the Georgia Clinical and Translational Science Alliance KL2 program, which is kind of what started my federal funding career. And recently I've made a transition to University of Colorado School of Medicine in their Department of Biomedical Informatics to basically study AI and ICU medications full time. So what I have a particular interest in is how can we use artificial intelligence and machine learning to make medication use safer? And being critical care by training, I've used the ICU as my use case scenario for a lot of things, particularly because the medications are, frequently high alert according to ISMP and things like that. And I would say I hesitate to call myself a total expert on EHR integration, but I am. I do think this is where the field needs to go, and this is certainly the kind of the work that my team is trying to advance. So.
No, that's incredible. And with a background like yours, I think bringing that clinical knowledge to AI and integrating kind of that forefront of technology and clinical expertise together is really going to, like you said, result in safer medications, patient safety, and also probably optimized healthcare.
Yeah.
So starting kind of from like a broad perspective, where do you see AI playing the most significant role in EHRs?
Where does one begin, one of the figures that I love is that the rate of medical knowledge that we have is doubling at an exponential rate to the point that, I think it's every 70 days right now it doubles. And that's just outpaces what any individual clinician can know. And so the idea that AI could help us to retrieve and organize that knowledge in a meaningful way is incredibly powerful. Um, I also think that as much as we think about, wow, wouldn't it be cool if AI could make new guidelines for us or something like that? I also think that there are some really simple things that the EHR cannot necessarily do. And one that I like to go back to is, I was working in the ICU, coming off of maternity leave, actually. And, so you can say that I was maybe a little tired compared to my usual. And I started to put in a vancomycin loading dose, and I got it all the way through the system until I realized that 3 days prior I had missed that the level had been like 60, and that was why the patient wasn't on vanc. Was because they had a high level, but nowhere in that EHR did it flag me to say like, hey, are you sure you want to do that? And so thankfully the error didn't occur. You can consider it a near miss if you want, but even something so simple as that, where an EHR or an AI bot could bring in what I would call multimodal information, stuff from the lab, stuff from microbiology, stuff from the flow sheet, stuff from dialysis, all coming together to say, hey, did you really mean to do this thing? Would be really, really powerful. And that's before you start getting into clinical decision support and the ability to, again, bring in different information and think through that. The other role I see is early detection. So there's early warning sepsis systems that are just really incredible at the ability to see sepsis before a clinician does. And then I recently saw a paper looking at heart rate variability that maybe improve sepsis detection 17 hours before those early warning systems. Like that's incredible to think about. So I do think between prediction modeling, kind of what I would say broad guardrails for patient safety, as well as organizing information would be really powerful places for the AI in the EHR.
Absolutely. When we talk about implementing these guardrails per se, I think there is probably an evaluation that goes through to make sure that, the implementation is safe and effective. So kind of, are there key factors that experts look at, or your team looks at to assess the success of these implementations?
Oh, there's so much to say on this particular topic. So I guess one hat that I can put on is you're a clinician, you're working in the hospital, and someone brings you their new AI tool, or you see a new study and you go, is this good or not? And one of the downsides right now that we face with AI-based studies is, one, in the ICU in particular, less than 1% of all those studies have ever been implemented in a patient population. So all you're seeing is that the algorithm worked on a data set. You don't know if it actually improved patient outcomes. Is kind of the equivalent to me of saying that the antibiotic worked really good in a test tube, and I have no idea how it works in a patient. That would cause you to pause a little bit to be like, what do you mean by this? Um, but then the other part at times is that I don't think we've always had a great connection between computer scientists and clinicians. So my example of this is I was at Society of Critical Care Medicine, and I was listening to this really neat prediction algorithm that had like 50,000 patients and 2,000 parameters, something. Just the computational power of this machine learning algorithm was incredible for risk of reintubation after you extubate a patient. And I was like, wow, that is a really cool, powerful thing. And I was like, well, how did it compare to the Tobin index? And they said, what's the Tobin index? And I was like, well, the Tobin index is one number divided by another number that gives you the risk of reintubation. And this is something that, anyone in the ICU is aware of, knows the number. You can do it in your head, and it works very well to give you a good reintubation risk. And they had never heard of it. And so to some extent, they had made this incredibly powerful algorithm that maybe never needed to exist at all. And so where I'm going with that story is, it's really important to benchmark against what's already out there. So if someone says, I've got a cool mortality prediction model, okay, how does that relate to SOFA? If I'm doing RSP, if I'm doing reintubation risk, well, how does it relate to the Tobin index? Those types of benchmarks. So those things are really, I think, very important. Another kind of pearl for clinicians is, has it been externally validated? So it's all well and good to do it in your data set at your local institution, but how does that face up against another institution, a different time? And many, many studies have not been externally validated. But when we start getting into true implementation and integration, this is something where I think as a field, we have a lot of work to do to put better, I don't know, guidelines, guardrails around what that looks like. I would like to call out, I think Duke's AI Health has this really neat framework. It's called the Algorithm-Based Clinical Decision Support Oversight, or ABCDS. And it's a whole website, you can look at it, but it has really, really thoughtful checkpoints of, okay, we made our algorithm, we developed it. Okay, we did a silent test. Okay, we did a pilot test. Okay, now it's live in the system. Okay, who's oversight? Just because you implemented it, what does that mean 3 years from now? Are we still using it? What are the errors? Who's monitoring all of those things? And I think being really thoughtful about what I would call the development life cycle is something that we have a lot more to do and to think about. And again, this is also something where, what is the role of like the FDA in some of these, is this a medical tool, your device, and what is the oversight that's going into that, much less the ethical regulations and all that kind of good stuff.
That's incredible. Also, the use cases, the examples that you bring about the ICU, I mean, that's incredible. Just me listening to it, I was like, oh my gosh, what a cool example. I kind of wanted to pick your brain on the second example a little bit. Um, uh, you mentioned computer scientists and clinicians working together. Do you foresee like clinical teams evolving to include a computer scientist, or a tech team evolving to kind of include that clinician, like how we have it at InpharmD? We have clinical pharmacists, and then we have computer scientists, developers who work together to work on our AI. Do you see the teams becoming a lot more multidisciplinary before kind of us seeing that implementation and then eventually those positive patient outcomes?
100%. I mean, I think the National Institutes of Health is very much all about team science and multidisciplinary, multi-professional type work. And this is absolutely essential. One of my best examples as I was talking with some computer scientists and a grad student, and we were going to do some prediction modeling with drugs. And they're like, yeah, so what I did is I just chopped off all of the rest of it and used the first word. And I was like, what do you mean all the rest of it? And what they meant is that something like sodium chloride, they just chopped off the chloride. It was just sodium. And so we did this first run of analysis with only the first word of a drug, but obviously that is not super useful, much less the fact that the dose might matter, much less that the formulation might matter. And, you could have seen like the pharmacist's eyes on the call, their eyes got so big like saucers. And the grad student's like, what? I don't get it. And the thing is, like, this grad student knows so many things that our team does not know. I mean, I couldn't pull up R and run that, that XG boost or anything like that, but had no appreciation for what medications, what the role of that is. So yes, I do think all of this is in a very translational space.
So you mentioned predictive modeling, which brings me to my next question about data modeling. So kind of what are your thoughts on how do we incorporate data into AI models for EHRs, and what are some common data models used in this space?
This is another kind of open space and a really important space that I think there are a lot of people that are working on, but we have a lot more to do. So, I think for folks that are not super familiar with a common data model, what a common data model does is it makes the data structured in a way where your institution's data looks like my institution's data, and then we can combine it. Otherwise, what happens is you get like an Excel doc, and the first column is drug, the next column is dose, but then in yours, it had route first and then dose and then drug. And you'd say, well, that's all fine. I can figure that out. I can copy and paste. But then what happens when it's, was it start time or administered time? Is it clear that it's start time versus administered time? Is it clear that, that formulation is a homegrown formulation versus something that's, you bought on the market? And some of those things are really hard to see based on how the data are structured. And so the purpose of common data models and data standards is to make to live into the FAIR criteria: findable, accessible, interoperable, reusable criteria. And that's super important for making, I was talking about how you want to know if that model has been externally validated. It's very hard to externally validate if you can't process the data in a way that the machine can read it. There's different, there's the, was it Fire 7, RX Norm is one for pharmacy space, particular OMOP and Odyssey are another one. There are kind of smaller groups that are working on different components for the common data models. Even, Epic has a proprietary version within how they kind of house their information, and Caboodle and stuff like that. So there's lots of different kind of like places where you can see this structure. But ultimately, I think that what we're looking for is how do we have, and it's okay, maybe there's multiple structures, they do different things for different purposes, but are there ways that we can make them talk to each other? I will tell you, the first couple of data sets I got, I just, it's like the ignorance of youth in a way, but it's like, I get it. I was like, holy cow, this is hours and hours of a grad student helping me to process the data. I mean, we're talking like probably a full semester just to do a couple of studies worth of pre-processing. And that's very slow when you start talking about wanting to make rapid advancements with AI.
Wow. And are there, like you mentioned, a couple different models and a couple different issues that we see with these models. I'm assuming there might be some reporting standards and frameworks that are also coming into play here, maybe to help ensure the data quality or data consistency. Like you said, sometimes, it takes a semester's worth to just analyze a few studies. Are there certain frameworks in place that we can apply here, or has that maybe that hasn't been established just yet? What are your thoughts?
There are frameworks for it, and but I don't think we've totally established what the best framework is. But I'm thinking right now there's the Consort AI, which is Consolidated Standards of Reporting Trials for Artificial Intelligence. There's another one called Spirit AI for standard protocol items for interventional trials with AI. There's also like Strobe. I think Strobe has an AI based one, and there's another one that's now that you're talking to me, I can't remember it, but it's like AIM something or other. But it's you can find on New England Journal's website where that's their reporting standards for what they want from AI studies. And what at first I didn't quite understand what's the purpose of these. The first time I got a paperback and they said, where's your strobe checklist? I was like, what are you talking about? Why do I need this? But then when you get into it, what they're wanting you to do is to be very systematic and methodical with how are you reporting what you did so that someone else can reproduce what you're talking about. And once I really got into that as a scientist, I was like, wow, this is so powerful to be able to think about this. And it makes your writing so much better. It makes the methodology so much clearer. Within the ICU space, a bunch of the editors got together from critical care medicine, Blue Journal, et cetera, and got together and kind of talked about prediction algorithms in particular. And they're basically like, do not submit a paper to us that doesn't meet these type of standards. And it's because otherwise it's kind of like fun with data, but it's all very much in a black box. And you'll hear black box for AI, and that can mean a lot of different things. But even, traditional logistic regression can have a black box component if I don't understand how you structured your data. And I think, an example for this is like, what do I mean by that? Okay, I put serum creatinine in my logistic regression prediction model. Okay, people know what serum creatinine is. That makes sense. Well, was it a continuous variable or was it dichotomous? Okay, how did I pick my dichotomous side of things? Another one might be something like white blood cell count, where there's a normal range, but there's also high and high and low mean different things. So again, did I put a continuous variable in? Did I do low, normal, high? How did I approach those type of gradations? And without kind of, being thoughtful to what that looks like, the assumptions that were made in the model, a clinician may balk at that and say, hey, I don't find that to be, face valid or whatever.
Yeah, absolutely. And like you mentioned, I think it comes back down to that external validity factor, right? Are we able to reproduce this again and get that same result? Is it just good data or fun with data, or is it something that actually transcends that and is meaningful? And I feel like it has, the way that AI is progressing, the way technology is progressing, I think there is so many ways it can be meaningful, but one of the biggest kind of roadblocks that we hit here are biases. With any type of data, with any type of studies, any type of new idea implementation, there's always going to be a bias. And we have, I think, kind of a twofold bias, right? We have the tech side and then we have like the clinician side. And so I kind of wanted to hear your thoughts on, what are some of the most common biases that we see with these AI models, and how do they impact patient care? How could we fix them?
Yeah, it's a big question, and I think, it's a classic, thing within meta-analyses is junk in is junk out. And so if you're using a data set that has bias in it, what you're going to get out is going to be biased to some extent. So the question becomes, how are you kind of like double checking or thinking about those things? And, I think like one of the ones that, again, using the ICU, but there was something that happened during COVID-19 is we realized that the pulse oxes we were using were not necessarily accurate for people that had darker pigmentation in their skin. And what that meant was that we were delaying care because we thought that their oxygenation was fine, and it wasn't. And because we were delaying care when they needed care, they had worse outcomes. Well, what that looks like is you get some reporting that's like, oh, like Black people died more often from COVID. And then people have something to say about that. And it's like, well, okay, let's unpack what that statement means. And what does that mean from a data set perspective, or from how do we even, analyze this? And so, there's bias everywhere to some extent. But I do think that some of the things that we need to be thoughtful about is specifically stratifying and looking at different things where we might see, racial or gender bias, and assessing that in particular. And then also trying to be thoughtful to like, what is the age of this data set? Do we think that data sets pre-COVID in the ICU are as meaningful as post-COVID? I don't know, like that's a very interesting question. We've learned a lot about steroids and respiratory failure as a result of COVID, where to some extent, I'm less trustful of an older data set about ARDS before that time. So even I call it well-meaning bias, which is just that, that to some extent that time is what's making it biased, is an issue. So I think one is being really thoughtful, I think, for both clinicians and researchers is tell me about your demographics, and make sure you've actually looked at your demographics and do you think that that is representative of the whole? And then being thoughtful to, okay, what are you really seeing for your outputs for different patient populations? And do you think that that is good or not? And is that being reviewed by a clinician panel and that kind of stuff? But I think, this is to me still a huge area for like, how do we do a better job? Because to some extent you can just like, well, it's biased, and you're like, well, it's all I've got, so I guess I'm going to go for it. I actually just got this back at a grant review. Someone was like, well, you want to use a data set with pharmacist interventions. How do you know that the pharmacists don't have biases in how they make decisions? And I was like, well, I know they have biases in how they make decisions. That's called clinical judgment. Someone might have feelings that they hate amlodipine. That's a bias, and it's going to be in there, whether that's good or bad. And so to some extent, it's like, what do we do with those things? And I don't know if I have all the right answers for that.
Speaking about that bias, and I love to ask all of our experts this question. Um, there are clinicians out there are pharmacists out there who are hesitant towards AI integration, whether that's with EHR or clinical decision support or healthcare in general. There are folks who are maybe like I've been told I would rather trust a pharmacist or a clinician who makes a mistake rather than an AI or a bot that gets it right. So kind of what are your thoughts on that type of bias? What would you say to those clinicians who are hesitant, who are maybe questioning AI?
Um, I would validate them because I do think that to some extent that's very true. So there's a vancomycin dosing software and it uses AI. And that's very neat that it gives you these cool, AI based recommendations. And I was with a couple of my buddies on a hiking trip, and my one buddy was talking about how much she hates it because the bot or the algorithm has no concept of dialysis. And so it gives you this amazing answer, but it doesn't know what to do with, serum creatinine within continuous renal replacement therapy. And so, what do you do with that? If you blindly follow the bot, you'd be wrong. And so to me, I think what we're really trying to get into is how does AI augment what the clinician is doing. So in that particular case, what I would prefer is that I say, hey, this patient is a good candidate for AUC based, AI based vanc dosing. I'm going to click on this and see what it gets and say, yep, okay, that checks out with my general thought process, as opposed to maybe the other way of saying, we're going to use this AI bot to make the decision. But I think it's more so about kind of that augmentation is how I would think about it. Um, yeah.
Yeah. And I love that you said that because that works very well with kind of what InpharmD is doing. We're using AI to like our AI is built to parallel the workflow of a clinical drug information specialist. And our entire goal is to optimize whatever the AI spits out rather than just sending an AI driven response. So I,
Yeah.
I love that you said that about the augmentation. And
Yeah.
kind of on that track, we have seen successful implementations of AI before. Can you share a few successful case studies where you've seen successful integration of AI with EHRs or otherwise, just in general? Kind of, are there any examples that come to mind?
The biggest one, and I think one of the more exciting ones, is the early warning systems for sepsis and early cardiac collapse, where these are, they're AI-based algorithms that monitor in the background and they look at vital signs in labs and all sorts of things. And based on their prediction algorithm, they send an alert up to the clinicians to go evaluate those patients. And what's neat about it is that, when you look at those particular vital signs in isolation, it makes sense that it wouldn't necessarily trigger to me as a ICU clinician to be like, oh, that patient really needs to get looked at. That's the beauty of the early warning system. And those systems have been shown that, like, when they are implemented and implemented thoughtfully, that they reduce mortality. And that's, I mean, pretty amazing to think about, that we are able to get antibiotics earlier, get you to the ICU faster, all that kind of stuff. And same with, like, ACLS certification or whatever, like one of the biggest things they say is the whole point, the best way to not die of a code is to not code to begin with, so like early warning systems for cardiac collapse, the fact that we can stop you from ever getting that far is huge.
No, that's incredible. It's been a long time since I've been like, in the clinical practice setting, but I'm just thinking about that and what it would be like to have those tools. And I mean, that's absolutely incredible in terms of really just resulting in better patient outcomes. Um, wow. Yeah, so Dr. Sikoria, we are on our last question. And thank you so much. Like, this has just been such an insightful talk, all the clinical use cases and examples. My last question for you would be, as we look into the future, we see AI definitely being a part of the future. What would you recommend to healthcare professionals? Should they start developing some more skills in the technology side? Should they learn more about AI? What would be your like last bit of advice to clinicians and pharmacists based on kind of where we are right now with AI and kind of where we're going in the future?
I think there's two sides. Don't be on the extreme of either side. On one side, don't be someone that, fights everything that AI and newer technology is providing, because I do think that, like, again, those early warning systems are really powerful and really offer us something that we wouldn't have been able to see otherwise. And that is incredibly cool. On the flip side, you don't want to be a blind follower of every output that we see right now. This is still very much, to me, even the best things are still to some extent in a beta phase of, what do we do with this information and how do we use it thoughtfully? And so, sometimes I have students that are like, I don't know if I really need to know this, because isn't the computer going to do this for me? And, one of the classic examples that I use, which isn't necessarily AI based, is go look at a drug-drug interaction checker. It pulls up 25 things. Are you gonna change those things? What's clinically relevant? And to some extent, even though the machine can provide you the 25 things, you still have to provide that interaction. So I really feel like, to me, the goal here is to figure out how we're going to work together. And I think of this a little bit like a team-based environment. Like, we work with physicians, pharmacists, nurses, respiratory therapists. No one is upset that you've got a respiratory therapist in the room providing their expertise. AI is going to be the same way to some extent, where you're going to say, this has an expertise that is going to augment what I'm doing, but it's not replacing me. It's just allowing for higher level conversations, more data-driven conversations, hopefully.
No, I think that is perfect. That perfectly sums it up. I know from InpharmD side, we are so excited to see where things are going, and I do think that there is room in the future for AI to really augment the clinical process and result in those better patient outcomes. Thank you so much, Dr. Sikoria, for sharing your expertise with us today. It was an absolute pleasure to have you on our show. And I mean, the clinical examples, the clinical use cases, ICU use cases, I know that's going to be something that's so useful and beneficial for our listeners. So thank you so much. We really, really appreciate it.
This was a pleasure.
And to everyone tuning in, thank you for listening. Be sure to follow us on LinkedIn, stay connected, and we will see you next time.